Buenos días, señoras y señores, ladies and gentlemen. Don't be afraid, I won't speak Spain because this was everything I know in this language. Let me turn your attention to stenosis from maybe some other aspects than we have discussed up to now. In the first couple of slides, I would like to tell you something about the stenosis in the view of fluid dynamics. We have a cooperation with engineers, experts in fluid dynamics, and they showed us many interesting things. First, we all know that the blood flow changes significantly just after the stenosis, and we see it also in ultrasound. And I put here a question: where is the flow velocity highest? Is it here in the entry, inside, or in the exit part? I was surprised because it is in the exit part. It is not directly in the residual diameter, but it is in the exit part. And the reason is that if we have a narrowing, there are several forces involved. The static pressure decreases thanks to Venturi effect, as we know from physics, and there are also changes of wall shear stress. But the blood flow makes turbulence here, and it is the turbulence which constricts the blood flow. So it's not the narrowing itself, but it is these are the fluid dynamic forces which narrow or cause the maximum stenosis. From the practical point of view, we have sometimes problems to measure the velocity directly inside the stenosis by ultrasound, for example, because of calcifications. But it doesn't matter because we can measure it just after or in the exit part of the stenosis, and it is even better. What are the local changes associated with stenosis? They are mainly characterized by wall shear stress, which is related to velocity, viscosity, and indirectly to diameter. And it's known that very high wall shear stress or very high velocity activates von Willebrand factor, which takes part in the coagulation, but also in endothelial dysfunction. And there is also some mechanical deployment of the endothelial cells inside the stenosis. On the contrary, in the exit part, there is turbulence, and there are areas of very low velocity associated with low wall shear stress, with changing vector. And we know from atherosclerosis that these are the areas where atherosclerosis develops first. And also probably these are the areas where intimo-medial hyperplasia develops first. So the fluid dynamics experiments have this arrangement. There is some pump, then model of stenosis, and the fluid goes back and so on. And it is possible to detect the pressure changes, and it is possible to visualize the flow using particle imaging velocimetry, which combines laser and ultra-fast video camera. Our colleagues made an experiment, and they compared the same degree of stenosis. It was 75% of area reduction, and they compared the coaxial stenosis with those who were asymmetric. And it was interesting that any asymmetry of stenosis further increases the pressure loss inside the stenosis. So any asymmetry is very important, and the higher is, of course, the degree of stenosis, and the higher is the flow rate, the more is this effect pronounced. Also, the stenosis length plays a role. This data come from experiments back to 1970s. If they compared the same stenosis but with various lengths, then the longer was the stenosis, the higher was the pressure loss. The pressure loss is something which is typical for all stenosis, and in 1990, Sullivan and colleagues measured invasively blood pressure in AV grafts, and this was the value in the artery, arterial anastomosis, graft, venous anastomosis, and central vein, in case there was no stenosis. In this case, the most important pressure loss occurred inside the arterial anastomosis. Nevertheless, if a stenosis developed in the venous anastomosis or close to it, then the curve was up, and of course it nicely explains why the patient could have hand edema, prolonged bleeding, and all these things. As we know, blood flow volume and blood flow velocity are interrelated, and the diameter stenosis close to 75% is associated with significant decrease of blood flow volume. We can non-invasively estimate the pressure gradient inside the stenosis, as we do it during echocardiography in case of aortic valve stenosis and so on. And these are, for example, the velocities associated with pressure gradient, means pressure difference between two sides, which is related from simplified Bernoulli equation. So, back to medicine. Stenosis percentage is something widely used, and it could be estimated by angiography or by ultrasound. As it was discussed already, we can do angiography and consider, is this stenosis significant? And what percentage is it? Do we compare it with the unaffected segment, or with the artery, or with what? Furthermore, there is an angiography limitation. Mostly the fistulas are visualized in a single plane, which is a problem because, sorry, maybe I will try to, no, sorry. If there is asymmetric stenosis, it could appear differently on the luminogram, which could lead to underestimation or overestimation of the stenosis significance. Of course, also stenosis percentage by estimation by beam mode has some weakness. It is our brain, our hand, but it is the effect of ultrasound setting, the effect of too much manual pressure on the examined vessel, some shadows of mostly by calcified tissue, inappropriate setting of the beam mode, and so on. Therefore, I would suggest forget percentage of stenosis. I think more important things include velocity, access flow or flow volume, and residual diameter. All these parameters could be perfectly visualized by duplex Doppler ultrasound. the velocity criterion is based on this relation, as we already as I already mentioned, and mostly 2 to 3-fold velocity increase is thought to be associated with a significant stenosis. There was some other work when peak systolic velocity above 4 meters in low flow vascular access was always associated with significant stenosis, and the authors concluded that even a simple Doppler can be used for this purpose, but I would not agree completely with their conclusion. There is some other weakness, such as aliasing, again manual pressure, but it should be emphasized that acceleration physiologically occurs in arches, physiologically occurs in arterial anastomosis, physiologically occurs in any irregularities, and so on. So there are some additional stenosis criteria, as I already mentioned. And if we look at the access flow volume, the decrease by 20 to 30% in comparison to the previous measurement is believed to be associated with significant stenosis. This is the parameter on which is based the flow volume surveillance by the dilution techniques. So it's one criterion, and the other one is the absolute value less than 600 or maybe even 500 in native fistulas. Flow volume is the function of the axis, and it is completely different from all other aspects of vascular ultrasonography, because we are usually not interested in flow volume of carotid arteries or femoral arteries or all these things, and it could be easily measured by ultrasound. But it is necessary to stress out that the flow volume should be measured in a straight segment, far away from any stenosis, far away from arterial anastomosis, far away from arch, and so on. It's not so easy to realize it in the clinical practice, but this is why we usually measure the flow volume in the brachial artery in the case of native fistulas, while we measure it in the venous part of the graft in case of AV grafts. Some authors used also resistive index as an additional criterion. Resistive index is explained here, and of course it's high in all of us in the peripheral arteries if we don't have any vascular access and do not work hardly, but it falls after the creation of shunt. Therefore, this was why resistive index was studied, but the results were conflicting, and I would say that according to my opinion, the high resistant pattern of the flow is important in the feeding artery, because it suggests that the shunt is closed, or that there is a significant stenosis very close to the arterial anastomosis. Another group used peak systolic velocity, BIMO narrowing, aliasing, and resistive index, and it helped to increase the sensitivity and specificity. Another option is to measure residual diameter of the stenosis. It was not possible 15 years ago when the maximum working frequency of our probes was 7.5 megahertz. Now we have more than 10, sometimes 15 megahertz or even more, and then the spatial resolution is perfect, and we can measure the residual diameter either in B mode or using BFI, which is a combination of color Doppler and so-called B-flow examination based on digital subtraction. The cutoff value, according to our opinion, is 2 millimeters. If it is less, then we send usually the patient to angiography. There are some other experts who say it could be even 1.5. Let's see. Of course, residual diameter could be measured also using angiography. So-called quantitative angiography is used, for example, in coronary arteries, but it is very seldom used in case of vascular access. There should be some other factors which influence the progression rate of the stenosis. It's the intima media thickness, it's probably calcification score, shear stress, presence of diabetes mellitus, and so on. And these ideas are by this guy, and you know it probably. But sometimes it is rather some clinical feeling which pushes us to the appropriate next step. So we use, as it was already here mentioned, so I would not go into details, but for the significant stenosis, we ask for at least one additional criterion, while if there is only velocity increase and narrowing, we call it borderline stenosis and recommend early ultrasound follow-up. And there are many patients who have borderline stenosis for a couple of months and without any necessity of treatment. The problem is that every PTA is an injury to the vascular wall. Therefore, if the stenosis progression rate of a virgin stenosis is low, after PTA, the restenosis progression rate is very fast. In cardiology, we say that PCI, in this case, makes from a stable stenosis and unstable stenosis, and so on. So this is why it's not. It is necessary to wait until the appropriate time before indicating PTA. Of course, there is some functional or practical approach to the PTA indication, and probably we all use it. And the first question is if the stenosis is symptomatic or not. Symptomatic are always or nearly always sent to some therapy. But the question is the access flow is sufficient for hemodialysis? If there are collaterals, and if yes, if they can be used in the future for punctures or not. If the patient suffers from thrombophilia, frequent hypotension, if it is last possible access for the patient or something else, and sometimes it is only clinical feeling or maybe sniffing, what is the most appropriate treatment choice for the particular patient. As it was mentioned, surveillance, we tried we used the definition of the stenosis I mentioned in our trial, which confirmed the profit of ultrasound surveillance. Fortunately, there are many enthusiastic colleagues, especially in Spain, in Catalonia, such as charming Dr. Ines Aragoncillo, who published very recently a similar trial, but she will introduce it to you herself. So back to my question, is this stenosis significant? I think we do not have enough information, so please do not follow your oculostenotic reflex. Do not follow your feeling, if I am in, I should do it, or something like that, and save the patient and the money. Let me conclude that the ultrasound offers very precise and detailed description of both morphology and function of the access, with the exception of central veins. PTA is a fast solution, but long-term problem. Therefore, strict criteria must be applied for stenosis significance and for the indication to PTA. So I would recommend do not bury surveillance too fast. And finally, I would like to invite you all to the next Vascular Access Society Congress, which is in Ljubljana next year. Thank you.